It's my pleasure to present Eric Kriner. So Eric, he is the lead respiratory therapist in my hospital, actually, Medstar Washington Hospital Center. He has a tremendous experience in managing mechanical ventilation on ECMO, and he's a great speaker and teacher for mechanical ventilation. He's going to speak to us about the fundamentals of mechanical ventilation, and its use while on ECMO. Thank you.
Good afternoon. How are we doing? Pretty good. Thanks for sticking around. So we are gonna kind of take a little bit of a deep dive into my specialty, but I'm gonna kind of bring it up to the surface and try to focus on some of the, I guess, emerging things that are coming out with mechanical ventilation management and how they relate to ECMO, okay? So I do have some conflict of interest. I do a ton of speaking all over the world, all over the States, for a bunch of different companies. I do a lot of consulting for a bunch of different companies, and I write stuff for them as well. I also have this disclosure. If you are unfamiliar with a gentleman named Dr. Gattinoni, he's from Italy. He's probably one of the titans of mechanical ventilation ARDS research. If you just Google him, you'll probably get 500 hits. He's just so unbelievably well published. But recently he has this review. I'm not sure if it shows up large enough. I think it does, but it's probably the single greatest opening sentence of any paper I've ever read. And I think only he can get away with this. If you can't see it, if you begin to read this article while hoping to find an evidence-based answer on how to set the mechanical ventilator during ECMO, in patients with ARDS, we suggest you stop reading here, right? And so that's kind of where we are with this. We're kind of off of the rails, right? And so there's not a lot of really high-level evidence that is in place right now, but I think it's emerging and it's coming, and we're getting smarter about it. So as we go through, we will get onto the same page with the mechanisms and the concepts of ventilator-induced lung injury. We'll talk about how to minimize it, how we can go about doing that, and then we'll discuss the potential strategies once we cannulate and put them on VV ECMO. So in terms of the prevailing concepts, when you start out on mechanical ventilation, clearly without ARDS, your primary goal is really to correct and normalize ABGs. And ventilator-induced lung injury and hurting them is kind of on the back burner, always thinking about it, but kind of this balance does exist. However, as patients become more and more acute and more sick, this balance really goes starkly in the other direction, where all you're trying to do is just not hurt them. Don't hurt the lung. And so there's a couple different mechanisms for ventilator-induced lung injury, 3 of them specifically here that we'll kind of go through: volume trauma, adalect trauma, and O2 toxicity. Pretty intuitive on that one. And that is balanced against a normalization of ABGs. You know, I learned, I'm 26 years into this, and I learned something probably on my 2nd week in the ICU that a really great attending brought me to the bedside and said, "Eric, look at this patient. Is that patient normal?" And I'm looking at him, I'm like, "No, Dr. DePhillips, that patient's not normal." He's like, "Then stop trying to make them normal. Just get them to live till tomorrow, and then we'll figure it out then." All right. And so that is something that has been really kind of, you know, front of mind. Don't try to make them normal in that you're just going to hurt them doing it. And so the idea behind this, the whole concept, is that if we look at this CT scan at mid-lung and we're attempting to put tidal volume into that space, it clearly has a whole bunch of places to go, right? And it's equally distributed, and there's fairly low pressure with that delivery of the tidal volume. However, if you take a prototypical ARDS patient that have you know, heterogeneity across the lung, and they typically layer out in this way with dorsal lung segments being more dense and focally infiltrated, and you try to put that same volume into a smaller space, clearly you're going to emit a whole bunch more pressure, and you're going to have trouble ventilating them at that lower pressure. Gattinoni coined the term a baby lung. So the lung isn't necessarily stiff. It surely is if you were to understand global compliance. However, the lung is just small. The usable space of the lung is small, and if you keep trying to put larger volumes into a smaller space, you're going to run into big pressure problems within the lung. And so that idea is the idea behind volume trauma. It is a pressure thing, but it is caused by putting too much volume into that lung. And so as you roll this forward and you think about lung volume itself and lung volume on the vertical axis there, we can clearly put too much in, and that is what we would call volume trauma in terms of overdistension. And the other idea here is that you can also put too little in terms of lung volume. I'm not talking about tidal volume, I'm just talking about the lung volume itself. Previous speaker talked about using pressure to just keep the lung recruited, and that holds true in this aspect. So this same CT scan slice that you see there in red is the mid-lung area, and that lung is collapsed but recruitable. And so therein lies an opportunity, but it's an opportunity for ventilator-induced lung injury, because if you do not keep it open prior to the installation of the tidal volume and instead reopen a otherwise closed alveolus, every time you reopen and let it close and reopen and let it close, you're going to damage that particular alveolar unit. And that mechanism of lung injury is called adduct trauma. And so what you end up with is this kind of whole Goldilocks thing where you can put too much in, but you can also put too little in terms of volume. And you kind of got to get it just right, somewhere in the middle there of that volume trauma and that adduct trauma. The other thing that goes along with this in terms of the lung and what you're using is the gas exchange arrangements that go with that. If you are on the adduct trauma side, which clearly some portions of the lung are and some are not, but the adduct trauma side is clearly a shunt unit. There is cardiac output that is not participating in gas exchange. And as you go all the way over to the other side of things where you are causing volume trauma, you're causing a dead space unit. So in terms of ventilator-induced lung injury, you got to get it just right. And gas exchange, you got to get it just right, or you're going to affect it at the high end and the low end of the lung volume. All right. And so what we have here are these ideas and these concepts of, well, how do I prevent that? I got the words volume trauma and adduct trauma, but how do I prevent that? And so we have these prototypical ways to go about doing so. In terms of preventing volume trauma, we're going to use a lower volume, and we land somewhere around 6 cc's per kilo of ideal body weight. And we're going to maintain an end alveolar inspiratory pressure, better known as a plateau pressure, of 30. And so we try to limit that plateau there and reduce the lung volume in that way. In terms of preventing adduct trauma, we would use a moderate level of PEEP here. And that hopefully would reopen those closed but recruitable lung areas and bring that lung volume up that way, putting us right in the middle of that Goldilocks scenario. Not too much and not too little. All right. And so you end up ventilating them with a lung volume that looks a little bit something like that. However, as we go forward and start to really, really deeply understand how we end up hurting the lung, we come to this really kind of landmark paper, which is the driving pressure paper in my world. In the respiratory therapy and the mechanical ventilation, this is ventilation world. This is fairly well known, but this is the inception of it. And so this was a huge, huge individual patient meta-analysis from the 9 previous studies of ARDS. It include 3,600 patients. And they were seeking to find, well, what is it that is most closely associated with mortality? And off the top of your head, you think, well, if I put too much volume in, then all of those are intuitive, and they kind of, okay. So, yep, I am good. So they sought to really answer that question, what is it and how do we hurt this lung? And so what they went through is line by line and did a retrospective analysis of each one of these parameters to answer the question, is this most closely associated with mortality, or is it associated at all? And what they came out with is that something called the driving pressure, which is the difference between your plateau and your PEEP, that is how you get it, is the most closely associated ventilator parameter with mortality. It isn't the plateau, it isn't the volume, it isn't all of those other things that we think and that we try to do the right way. It is the driving pressure that is the most closely associated variable. So these are relative risk curves here, and we'll take volume, not to totally get in the weeds, but I think it's worth it because the picture kind of says 1,000 words here. And so if we look at volumes greater than 6 cc's versus less than 6 cc's, there is no difference in the mortality outcomes of these patients. You take the plateau pressure greater than 30, less than 30, those lines are on top of each other. However, if you take driving pressure, you reach a very clinically and statistically significant difference between mortality with this driving pressure. And if you place this on a relative risk of death curve, where you cross 1, you have an increased risk of death. That line is somewhere around 14. So your goal here is now not only to prevent volume trauma, but to prevent atelectasis trauma, but to also consider what you do in between those two things, which is essentially the driving pressure, right? And so the idea behind this is just really simple. Medicine's kind of hard, so just make it easy whenever you can. It's how far you stretch this rubber band, right? And so if I put PEEP and plateau up here and I stretch it really, really, really far, that's going to kind of hurt that rubber band if I stretch it really far. However, if I don't stretch it as far, thereby lowering the plateau and thereby lowering the driving pressure, that isn't as harmful. The other one that isn't as intuitive as just decreasing the plateau is actually increasing the PEEP, right? And so if you increase the PEEP, your starting point from where you start the stretch, you can also decrease the driving pressure. That is provided that you actually open the lung with that increase in PEEP, all right? You have to make the space bigger. You have to make the baby lung bigger in order to put the same volume in and create a less or a lower driving pressure. So that is kind of a qualified answer, but maybe perhaps one of the best answers that you come with. So you go back and you say, all right, well, I will protect the lung with too much volume and too much pressure. I'll put on a moderate level of PEEP, and I will now pay attention to what I'm doing in between, which is called the driving pressure, and try to maintain that less than 14. And so this is where you come out with the mechanisms and the concepts of ventilator-induced lung injury. What this leads into is essentially the management prior to ECMO. And the ARDS roadmap is pretty blurry. We have a couple decent ideas and a couple decent studies, and this is what we do, right? And so the problem is that we only got these two, which are strongly supported. They come from landmark papers. We do decrease the volume, low plateau pressure ventilation, and we should flip them on their face and use prone positioning. Two landmark studies that kind of helped along the guidelines that were produced by, basically every major medical society on the globe here said that we should be doing this, leading towards ECMO. And so you end up with this roadmap that says, all right, they have ARDS, we should low tidal volume ventilate them, we should flip them in the prone position. But the problem is that you run out of road really, really quick with a lot of these patients, right? And you end up at the end of this story, well, all right, I did those two things, now what, right? Now what? Now what do we do? And so my thought and my issue here is that, that's kind of cookie cutter recipe medicine, right? That's protocolized medicine, which I firmly believe in protocolized medicine. This is not what I'm trying to say here. But what you have to really, really appreciate with protocolized medicine is that you treat everybody the same at that point, right? And what we know from the mortality of treating those patients is that it's still hovering about 30 to 35%, even though you do those two things perfectly correctly, right? And so 35% of these patients, you're going to have to figure something else out, right? You're going to have to figure out the plan B. Where do I go from there, right? And so you're going to have to pluck this guy out of protocol and really, really individualize their mechanical ventilation strategy. And so the first thing that I gave you, driving pressure, is an individualization of mechanical ventilation, right? It is using a volume for that patient that even though you check the box of 6, and even though you check the box of a plateau of 30, if your driving pressure is still 18, that's too much volume, right? And so you're starting to individualize them based on this idea of driving pressure. That's number one. Number two is this whole idea of transpulmonary pressure. And I'm not going to get in the weeds with this, but I just want to kind of put it out there because it's starting to emerge and more facilities are starting to use this idea to guide mechanical ventilation. And that is, the transpulmonary pressure is the difference between the pressure inside of the lung and the outside of the lung, more specifically the pleural space, right? And so we use esophageal pressure, which is a validated surrogate for the pleural pressure. So if you think about it, if I put just a binder on your chest and I put a volume of gas into your lungs, the pressure is going to breathe really high off of the ventilator. However, what the ventilator can't do in terms of a plateau pressure is tell you how much is from the alveolus and how much is from body habitus or the pleural space. It doesn't give you that. It just gives you the big number. You have to drop an esophageal balloon in order to elucidate and separate the two types of pressures. Right? And so we use this a lot. I mean, we've dropped well over 500-600 balloons now. We put it in everybody now because it's eye-opening. It's so underappreciated, the contribution of the chest wall and the pleural pressure. And so this is how we use it. Essentially, if you have a PEEP of 12 sitting here, and we then measure the pleural pressure to be 18, the 18 surrounding the outside of the lung is pushing in, whereas the PEEP of 12 on the inside of the lung is trying to hold it open. And clearly here, the 18 is going to win, and you're just going to have massive atelectasis everywhere, and you're going to be struggling with your mechanical ventilation strategy, whatever it is. All right, and so we use it to guide PEEP, and in this particular case, this patient would probably go to 20 of PEEP at this point, right? And that is an individualized mechanical ventilation strategy just for that patient, right? We don't check a box, we individualize it at that point. We also individualize the plateau pressure, right? Just with that same idea that I just told you, the patient has a binder or large body habitus or an intra-abdominal hypertension that is creating a whole bunch of pressure pushing into and up through the thoracic cavity. That plateau pressure is just going to read high all the time. And you need to understand, well, what is the alveolar pressure? And so in this case, if I measure the alveolar pressure or the plateau pressure at 34, but I measure the outside, the pleural pressure of 22, well, 22 centimeters of the 34 isn't from the alveolus at that point. I'm still safe with a plateau pressure of 34. All right, and so this is how we use it to guide mechanical ventilation, just for atellect trauma and volu trauma in a personalized space at that point. And so we end up with an algorithm that looks something like this in increasing acuity. We follow the rules, we play by the rules, we do evidence-based medicine, but at some point you got to hop off a protocol if these things aren't working and be able to utilize some sort of strategy going forward. So we get to the idea of, well, what do I do on ECMO now? And I firmly believe you don't forget anything that I just said, because it still applies. It absolutely 100% still applies as we go forward. As we start to mature in the evidence base, this is, I think, probably going to kind of take its course and start to be better understood that we can't cookie cutter these guys, right? And so one of the big guidelines that came out, this was a 2014 paper, started to speak to these ideas of lung injury, and they really said, all right, we got to fit them into this box, this Goldilocks thing of not too much and not too little, and went really, really conservative with their approach, right? And so this is the entire, all of the guidelines from all of the different medical societies. I'll break them down and I'll just put them in the pictures for us here. This is ELSO, which is essentially 10-10-10 strategy, right? And so you end up with 10 of PEEP and then 10 of inspiratory pressure, and you end up with a total pressure of 20 at that particular moment. This is the REVA guidelines, which you can see look remarkably similar. Everyone's kind of going into that box that I painted for you, right? And so then we go to the Caesar trial, and the ventilator settings that they used, remarkably similar. And finally, you're going to end up with the Olia trial, and you end up with the same picture painted across the entire guideline, whatever it is, or whatever study that you pull mechanical ventilation strategies from, which is kind of a low PEEP, somewhere around 10, and you don't want to put too much in and exert too much pressure, so keep that around 10. I will point out here is that if you're going to do this, you're kind of checking those boxes with the PEEP and atellect trauma and volu trauma, as well as the driving pressure here, right? And so those are all good ideas, and it comes forward here with a pretty large individual patient meta-analysis that was looking at, well, what is it that is associated with better outcomes in these particular patients? And so the first couple graphs that you see here, there's no difference, the orange being survivors of ECMO, the blue being people that died, and you can see that there's no real difference between those different parameters. However, if I put up a driving pressure, you see there it starts to separate itself. And the conclusion that these authors came to was a low driving pressure was independently associated with improved in-hospital mortality on patients on ECMO, the same way that ARDS patients off of ECMO is the most closely associated variable with this. Most of these are observational studies and have been pretty I think, forward in saying the most closely associated variable. There are no prospective randomized control trials. We do not have causal data yet. And so those are starting to come out. And what I'm kind of talking about, should we personalize and randomize patients to a low driving pressure strategy, or don't really pay attention to it? And then we'll start to find the answers with this. As we dig a little deeper into, well, what else can I do to personalize this, in keeping with that same idea that I can't forget about anything that I did before ECMO. There is a prospective randomized controlled trial about the use of transpulmonary pressure to set your PEEP, as opposed to just picking 10 out of a box. They just gathered a bunch of pretty smart dudes, probably had a few beers, and said, all right, let's pick 10. And that's what we all ran with at this point. But you have to individualize this. And I think if your patient makes it to ECMO, they probably beg and deserve this at this point, right? And so we put balloons in these VV ECMO patients to try to figure out what PEEP that we actually need to set, because if we continually injure the lung, we're never going to get out of the hole that we've dug ourselves there. And so this was a single center prospective randomized controlled trial. I'll show you that the characteristics here, I have a couple of them duly noted, that they were pretty young. This was a study out of China, that they were pretty young. They had really low BMI in the mid-20s, and I was down at the bottom, they were only on the vent for 24 hours, right? And so this is the study population that they kind of studied, which is probably not who you are cannulating. So not sure how generalizable it is, but this is what they went with, right? And so the lung rest strategy is your typical 10-10-10, but they use a transpulmonary pressure guided strategy to set the PEEP. They cap the pressure at 25, but whatever your esophageal pressure PEEP was, that's where they set it. So if it was 18, you got a pressure control of 7. If it was 20, you got a pressure control of 5. They let the PEEP float, and they cap the total pressure at 25 there. And I'll point out the respiratory mechanics as we go here. The top more solid black line is that of the transpulmonary pressure guided. And so you can see as you go across here, the PIP is the same because the PEEP was higher. The PEEP was higher, and then the PIP was the same, and as a result, the volume was lower. And you can see that the driving pressure is also lower because of that, right? And so they're kind of following the rules. They did get lab samples of cytokines. You can see in the same idea that they protected the lung by setting the PEEP more appropriately for each individual patient. All right, the inflammatory mediators were much lower in the esophageal pressure guided group, and the anti-inflammatory, the IL-10, was much higher. Right? As you come to the outcomes, you can see here that the outcomes were better. I'll let you read the slides because I got a 10-minute warning over here, but I'll let you read the slides that the esophageal pressure guided group performed much better to a statistically significant difference, right? And so you get to this idea, this is just a Kaplan-Meier curve, that they survived. They survived, they got cannulated, and they had shorter runs because we personalized that. We then come to proning position, which Dr. Zakuk kind of just asked about, and should we be proning these patients? Because the guidelines tell us to do it when they're not on ECMO. We cannot forget what we know is the right thing to do just because we cannulate them, and then throw everything else off to the side. And so you can prone these guys. We do quite a bit. All right, and if we need to prone them, we prone them. The evidence is maturing. These two studies here were prior to COVID, and then there's since COVID, because the sample size just got big enough for everybody to do whatever they wanted for research. There's been subsequent studies. I'll show you this EIT guided group because I'm going to get to that hopefully. I got 5 minutes. Pictures, again, 1,000 words up top. EIT is something called electrical impedance tomography. If you look right here, it's essentially a breath by breath. It's a bedside breath by breath gas impedance measurement. The brighter it is, the more gas is in the lung. The bluer it is, the less gas is in the lung. So you got a breath by breath CT scan essentially, right? And so what you see is that if you prone patients, you drastically increase the size of the lung. That baby lung got much bigger. I will point out here is that there are non-responders and responders. You can't just PEEP anybody, you can't just prone anybody, because people will respond differently to them, right? And so you got to be able to have the smarts to know, all right, I did this, but is this working? I'm going to fast forward a little bit here. unfortunately, I'm going to skip my friend's my friend's paper, but proning works is, I think, the message that I want to leave with you for these particular patients. All right, I'm going to talk about spontaneous breathing because we can talk all day about what to do hours 0 through 96 or something like that, right? Where everything is nice and tightly controlled, but it is, what are those subsequent days look like? And we want them to breathe, and that's a good thing, right? Because what we do there matters. This, I have no idea. Like, there is no data, no, what should we do day 4 through here in this space on the ventilator, right? They tell us how to set it up, kinda, and we use our smarts, kinda, and we apply it, but this part of the road is really, really blurry. And I just want to give you some ideas as you go forward. If you lock in a volume of 6 cc's, you think you're being safe. However, if a patient has vigorous inspiration, there's something called a pendulum. And because of the differences in the lung, whether they're recruited or de-recruited, the de-recruited being on the left, your right, sorry, at the basis of the lung, when a patient goes to vigorously inspired, the change in pleural pressure is not the same across the lung as it is in a healthy lung. In fact, in the dense focal infiltrate in the dorsal lung segments, the change in pleural pressure is much higher because that pleural pressure has to open that alveolus up. All right, and so what ends up happening is that even if you put 6 cc's into this patient, it's going to go to the highest change in pressure. And if that highest change in pressure is down there in an airless lung, when the patient vigorously inspires, even though you're locking in a low volume, you have no idea where the volume is going to go. And the patient pulls it to that dependent lung segment, which is ill-equipped to take volume in because it was previously closed. So you're not only going to rip it open without electrauma, but then you're going to over-distend that area. And that's called a pendulum effect. If I light you up on a PET scan, you can readily see the differences. The green being where air is, the orange being where air is not. And you can see at end expiration, there's no air. But if you let a patient vigorously inspire and they look bad to your eyeballs, think of where the gas is going. Where it's going is to where it shouldn't go, where you don't want it to go. And so this whole spontaneous breathing thing, although great for your diaphragm, great for all these other facets, you have to be careful with it. You have to be careful with it, right? Even if you're using pressure control ventilation, it doesn't mean that you're capping their alveolar pressure, because in PC ventilation, you set the airway pressure. You never control alveolar pressure. So just back away from that idea right now, right? And so you get this idea where if I want the lung to be more homogeneous, I have to increase the PEEP and open that up. All right, and so that is one kind of idea as we go forward, to pay attention to vigorous inspiration because it means something, and just think of where that gas is going. This is how I look at the ventilator, typical pressure control waveform, and I have this idea of an iceberg phenomena. You see what's on top, that's on the ventilator screen, and so that's your pressure airway graphic there in red. And what you have to imagine is everything that's underneath. And that's what's going to hurt you, because if the patient sucks in really hard and they drop their pleural pressure really, really low, that difference between the airway pressure and that basement of where they drop the pleural pressure, that is your transpulmonary pressure. And they will hurt themselves at that point. The mechanism is called patient self-inflicted lung injury, or PSILI. The research around this is unbelievably forthcoming, and we're going to know a whole lot more of how to handle a spontaneously breathing patient as we come forward, okay? So I will stop here because I had some really, really geeky, nerdy things about how to monitor these guys. Maybe we'll talk about them in the workshop tomorrow. But you can get an idea of, is that too vigorous or is that okay? And we can do that every single day on any ventilator. It doesn't matter which one it is. All right, good enough?